I'm Dr. Alok Nath. I'm professor and head of pulmonary medicine in Sanjay Gandhi Postgraduate Institute of Medical Sciences. And I have selected this topic, which is of common interest for physicians, respiratory physicians, both. And it's a common respiratory disease like asthma and COPD are common occurrence. And we have got a lot of advancements in inhalation therapy, and there are lots of myths about the use of inhalation therapy in asthma. So, beginning with my talk, I would briefly go through the history of aerosol therapy. The history of therapeutic aerosol dates back to 1500 BC, when people used to burn some herbal plants, and smoke from that was inhaled through a stalk of a reed, and this diagram is a schematic representation of the same. And in history, the most notable contributions about the therapeutic aerosol delivery came from Yoga Ratnakara, that is from India, in which there was description and modification of smoking datura leaves for treatment of asthma. Charak has also described the same, in which burning of herbal composition in a couple of bowls, which with a fitted tube above it, and fumes were inhaled. And the therapeutic effects of the herbal component was described by Sushruta also, which had actually derivatives of atropine, which is actually the active ingredient of Datura stramonium species. The first diagram of an inhalation device was given by an English physician in 1654, and this drawing is the oldest illustration of an inhalation device. The first commercialization of an inhaler device came through the Mudge inhaler, in which a small pewter, which is actually a alloy of antimony and silver. These are utensils made of antimony and silver, containing of a lid and adapter, which is connected to about a 5 or 6 inch long flexible tube through which patient could have inhaled. And opium with hot water was inhaled for 20 to 30 minutes, and they described it in a textbook as the miraculous response of catarrh's cough. And these things were marketed and advertised in a very large manner in Western world at that time. After that, various ceramic inhalers, which was functionally or visibly similar to that of Mudge inhaler, came into practice and gained a lot of popularity in England subsequently. The later half of the 19th century was overwhelmed with innovations in the area of therapeutic aerosol delivery technologies, with nebulizers, dry powder inhaler devices, advances in other delivery technology, commercialization of asthma cigarettes, which I'll be talking just now. And in 1852, of the first DPI device, which was similar to the current device, the diagram, schematic diagram of which is shown adjacent in the adjacent diagram. These are the cigarettes. These are the cigarettes which were called asthma cigarettes, named Marshall cigarettes and Dr. Wetzel's cigarettes. And they were actually made from the concept which actually originated in India which I just described in the earlier slides. And they were introduced in United States by Philadelphia physician Samuel Cooper, and in Great Britain by General Gent when he returned from India. These cigarettes gained very rapid popularity in people, because they actually contain the same anticholinergic drug and atropine, which were atropine analogs, and they had good bronchodilator properties. And as you all know that there are structural analogs like ipratropium and tiotropium are still they are the critical components of asthma and COPD therapy today. And the positive point was that the extra fine nature of the smoke of the cigarette resulted in exceptionally good concentration or deposition in the lungs. and which were not even achievable by delivery devices used in the first half of the 20th century. As a result, there was a lot of therapeutic relief to the people who were using it, and this is why asthma cigarettes gained a lot of popularity, and they significantly outweighed their potential harm initially. But undoubtedly, later on, it was all recognized that these cigarettes contain tar and a lot of toxic substances which would prove detrimental to lung function. And today we all know that smoking, cigarettes or tobacco consumption is the first and the largest contributor to risk factor of various malignancies, including lung cancer. So the first dry powder inhaler device was invented by a Boston physician, Ira Warren, in 1852. The trade name was Aerosol, and which was a tube in which was a double layered tube in which the outer tube was there and the inner tube was there, and the inner tube was enclosed in the outer tube with a mouthpiece. And when the inner tube was twirled with a small knob, the powder would used to be aerosolized through the holes and delivered to the patient. And similarly, a carbolic smoke ball was invented by Frederick Rowe in form of a device which consisted of 5 centimeter hollow ball which contained the adjuvant, the delivery drug as well as the excipients. And when we press the rubber ball by shear forces, the aerosol would have come out and the person would have inhaled it. These are the diagrammatic or the photographic representation of both the DPI devices. These devices became very popular, and in 20th century, two important classes of drugs, that is the beta agonist and corticosteroids, were also discovered to be the very important and helpful and beneficial for the treatment of asthma, and they became increasingly prescribed. Several studies demonstrated the benefit of beta agonist and corticosteroids in management of asthma, and inhaled epinephrine delivered by nebulizer became a prominent therapy for treatment of asthma. By mid-1950s, the aerosol delivery by beta agonists, corticosteroids, and anticholinergics had all been demonstrated to be effective for treatment of respiratory diseases, and convenient delivery by dry powder inhaler or a squeeze bulb glass nebulizers was demonstrated, but their limitation had set for the development of more or innovations of more pharmaceutical devices, which later on came into being. This is the diagram of the first meter dose inhaler, and it was a result of inquisitiveness, or you can call a frustration of a patient called Susie, who questioned her physician that why can't somebody put my medicines in a gas which I can easily inhale. Stimulated by this question, Riker Laboratories started beginning testing of the chlorofluorocarbon gas as the vehicle or the propellant gas for the use of delivery of these therapeutic drugs, these therapeutic compounds, which could be mixed with the chlorofluorocarbon gases. And they first started experimenting on Freon 12 and 114 with mixture of 35% ethanol. And that led to the discovery of the first inhaler device. And the introduction of the first inhaler device in 1956 was the major breakthrough in the treatment of respiratory diseases, particularly asthma. And meter dose inhalers were the first device that achieved significant drug delivery to the lung, and they were portable, easily to carry, and convenient, truly convenient devices, in which later on add-on devices were also added. In the same time frame, two more important DPI devices were also commercialized, that is the spinhaler and the rotahaler. The schematic diagram of both the devices are shown here. And in addition, there were also breakthrough in asthma therapy because of discovery of albuterol, which was the first bronchodilator which gained or more, I mean, one of the perfect bronchodilators which were introduced in the earlier 20th century. And also there were discovery of some more drugs like cromolyn, sodium chromoglycate, and other corticosteroids like the clomethazone propionate. Later on, atomizers and nebulizers were also invented. Atomizers are devices in which liquid could be broken by into fine particles, but they lack the baffle system. And the nebulizers are nothing but atomizers that contain a baffle system to remove coarse droplets from the air stream, and thus provide aerosols that are more likely to deposit in the lung. This we would understand what I'm talking about the amount of droplets, the coarse nature or the fine nature. What is all this? We will be briefly touching upon the physiological properties of aerosol and the basics of aerosol dynamics. What is an aerosol? Aerosol is defined as suspension of liquid or solid in a gaseous medium. And aerosol system includes the drug, the aerosol device, the disease, that is the target site, and the patient's respiratory system. And the deposition, absorption, metabolism, and elimination are the essential determinants of the pharmacokinetic profile resultant from the aerosol system, which depends on the emitted dose, that is the amount of dose which is emitted from the aerosol system, and the fine particulate fraction, which is the mass of the particle below a cutoff diameter, which is actually the determinant of what amount of drug will be therapeutically beneficial to a person. The overall efficiency of the aerosol system is composite of emitted dose and the fine particulate fraction, which is the determinant of lung bioavailability. And bioavailability of the drug is influenced by the patient factors also, such as airway, lung anatomy, drug permeability across the membrane, the metabolism of the drug, and phagocytic clearance of the pharmaceutical in the lung. The efficacy of aerosolized drug depends on dose deposited at the target site and as well as the distribution in the lungs. The aerosol or the particles which are emitted by the aerosol device deposit in the lung by three methods, that is inertial impaction, that is by the mere weight of the droplet or particle, gravitational suspension, which occurs in the distal 5 to 6 generation airways, and below that, that is at the alveolar level, the effect of the main drug deposition is because of sedimentation and diffusion, which in which the weight or the volume of the particle does not have much of significance, but it is the airflow or the dynamics of the airways at that level. So the factors affecting the aerosol drug delivery are the amount of aerosol, which is self-explanatory, the anatomy and geometry of the airway, the size and physical characteristic of the aerosol, the density, temperature, and humidity of the carrier gas, and the ventilatory pattern. Coming one by one, in very shortly, the airflow in the lungs is not homogeneous throughout the lungs, even in health. The result in an upright patient is that the apical portion of the lung receives the deposition, which is double as compared to the basal region. This difference is significantly reduced in the supine position. In most lung diseases, there are regional heterogeneity, which adds to the regional airflow and important determinants of aerosol deposition. For example, it has been shown that there is lower deposition in the areas of poor air flow. Now, coming to the physical characteristics of the aerosol, this is the one of the most important part. That size of the aerodroplets is generally characterized by the MMAD, which is the mass median aerodynamic diameter. It refers to the particle diameter that has 50% of the aerosol mass residing above and 50% of the mass residing below that diameter. And any droplet that is larger than 5 microns is likely to be filtered out in the upper airways. Aerosol, which is less than 5 micron in size, readily reach the distal airways or respiratory tract, and particle size which are lesser than 2 micron is ideal and is able to percolate right up to the peripheral airways. And adding to that, the aerosol containing drugs with hygroscopic properties are likely to increase in size in humid conditions that may have adverse impact of the delivery of the drug. And another determinant is the GSD, that is the geometric standard deviation, which is the measure of the particle heterogeneity, and median diameter upon the diameter of or diameter one standard deviation from the median, and particles of uniform size with GSD less than 1.2 are called monodisperse. So this is the thing which I was just talking about, that aerosol which are generated from nebulizers are of various sizes, and they are called heterodisperse. That they are of various sizes, which can be 5 micron, 5 to 10 micron, less than 5 micron, or even of different sizes. That is called heterodisperse. And those particles which have uniform size, which is determined by the geometric standard deviation of that particular particle, are called monodisperse. And these are the aerosol which are generated by inhalers and new generation nebulizers also, which are able to generate all the particles of the same size, and that increase the therapeutic efficacy of a given aerosol. This is a table which can show you that what happens with the size of particle size and where do they get absorbed, which I just narrated in the previous slide. The density of the aerosol suspended in the light carrier gas is in constant Brownian motion, and collision of particles decrease their MMAD and increase their deposition. The temperature and humidity also have got important effect on drug deposition. That is, cooled aerosol gains temperature in the upper airways and decreases in size, and the heated aerosol cools, increases in size and deposits larger. Now coming to the ventilatory pattern, the way a person breathes has a very important impact on the drug deposition. A basic minimal inspiratory flow is required for deposition of adequate deposition of aerosols, and flow of around 0.75 to 1 liter per second is considered good for aerosol deposition. In general, high flow rates are required for dry powder inhalers as compared to meter dose inhalers, and the higher the flow rate, the turbulent it is, and it results in aerosol fragmentation, and it decreases the deposition. In higher respiratory rates are also associated with poor aerosol delivery, and a slow deep breath with end inspiratory breath hold for 10 seconds is considered to be optimal for aerosol impaction in the small airway. This was in brief about the aerosol dynamics. There are various drugs which can be administered aerosol, and now coming to the practical part of it. Various bronchodilators and inhaled corticosteroids like beta agonist anticholinergic agents are the most commonly used drugs delivered through aerosol. Prostacyclin analogs, mucolytics, and a large variety of antibiotics can be delivered by aerosol method. But why aerosol therapy? Aerosol therapy has gained attention for respiratory diseases because the delivery of the drug is directly at the target organ. Higher concentration is achieved in the target organ, that is the lung. It has a fast mode of action and less systemic absorption, and resulting in less systemic toxicity and adverse effects. But it has got some negative points also, that it requires patient understanding of the device use, and there are the devices currently available are not perfect, and they still have a lot of limitations which have to be overcome. Now, what is a perfect inhaler device? A perfect inhaler device is a device which generates small particles which are monodisperse, which has high deposition in the lungs, which does not require much of explanation to the user or the patient, gives largest patient satisfaction, less of coordination required between hand and mouth. It should be easy to carry along, and it should be giving excellent patient compliance. Although a perfect inhaler device is still to be invented, but there are a lot of inhaler devices which are into practice, and a good quality devices are now available for use for treatment of obstructive airway diseases, such as pressurized meter dose inhalers, which are commonly called MDIs, which are used with add-on devices like spacers, holding chambers, and masks. Dry powder inhalers, that is DPIs, which can be unit dose or multi-dose. Recently, breath-activated inhalers have also been introduced, and nebulizers, which could be of mainly of three types: the jet nebulizer, ultrasonic nebulizers, and mesh nebulizers. Coming to the common ones, that is the MDI and DPI. MDI are propellant-based, in which chlorofluorocarbon or hydrofluoroalkane can be used as the propellant gas. However, higher CFC have been completely withdrawn, and all the inhalers have been shifted to hydrofluoroalkane because of the ozone effect. They come in suspension or solution form. They contain a lot of lubricants and surfactants. They are discreet and quick to use. They have got reproducible dosing, and they generate homodisperse fine particles. However, coordination is necessary for the use. DPI are non-propellant based. They are solid particles usually containing lactose, and patient controls the inhalation, and they are quite flow dependent. That is, their patient's flow determines the amount of aerosol which is delivered into the lungs. MDIs are the most widely used delivery system. They are small and convenient to carry. They are simple to use, independent of the inspiratory flow, and they usually are used with add-on devices such as volume holding chambers, VHC, that is volume holding chambers, and spacers, which can enhance the drug delivery. These are called spacers, which can be classified into three forms, that is simple tube extensions, holding chambers, and reverse flow devices, which come with the various brand names. These are the diagrams of spacer devices in which you can see a simple tube extension, holding chambers, and reverse flow devices. Now, there are some problems with MDIs, that is, they are highly technique dependent. There is a lot of coordination required between the patient and the device, and the person has to press the knob and has to coordinate immediately, take a slow deep inhalation immediately after, as soon as or simultaneously as he presses it. He has to hold the breath for 10 seconds, and if not taken properly, or if the patient is unable to understand the technique, it is very much possible that you get no drug into the lungs if the technique is not good. High velocity of the drug spray causes a lot of deposition in the oropharynx, and priming is needed if the device is not used for more than 12 hours. And the problem with propellants and the various controlling agencies leading to changes in the propellants, which I just told, that Montreal communication was given when chlorofluorocarbons were completely taken away from the markets, and there are problems with the propellants. The device spacers are also fraught with a lot of problems in which they can be device related. That the electrostatic charge associated with both aerosol from the inhaler anterior surface of voluminous chambers, and sometimes the valve function is not proper, and valve has stuck or it has got closed, the drug delivery will not be patterned, and size of the volume holding chamber of the spacer in relation to a patient breathing pattern, which is more important in infants and in small children, can also lead to inconsistent drug delivery. And face mask to seal integrity in cases of children in which we use the spacer with face mask or a sealed mask, which also has got a very important impact on the drug delivery. As there are some problems with the patients also. If you do not choose appropriate VHCs, and the patient interface according to the type of patient, like infant or a child or adult, and how the patient inhales, and disease severity and modality. They all affect the drug delivery to the lungs. In general, pressurized MDIs with spacers or volume holding chambers have demonstrated superior deposition efficacy over nebulizers in various studies. DPIs, that is dry powder inhalers, do not have propellant or inhalative breath synchronized or breath activated, and produce little variation in the particle size. They are preferred device in various patients in which you do not have much time, or a very busy OPD outpatient department where the resources are limited and time for training and teaching is less. And DPI has got more conversant usage profile as compared to MDIs. Poor respiratory reserves and diminished patient efforts are critical barriers to achieve the desired drug deposition with the effective use of DPIs. DPIs are presently used in stable and unventilated patient groups, and both MDIs and DPIs are limited by formulation available to be delivered by these devices. To overcome all these problems, breath-actuated MDIs were introduced, and breath-actuated means the device will fire only once the patient has generated a set negative flow and it gets activated and the aerosol is generated. It overcomes the problem of coordination and actuation, which was the major problem with metered dose inhalers, and it is activated with a resting flow rate of as low as 20 to 30 liters per minute. It has got a feedback mechanism, that is an audible soft click or a whoosh sound which confirms that dose has dispensed, and it totally patient dependent. It is triggered by the patient's respiratory effort. It is easier to teach, and it is indicated for adults, elderly and children, and can be used in difficult situations, that is in acute during acute attacks also. Breath actuated MDIs showed a very good deposition as compared to usual pressurized MDIs. This picture shows the radio labeled particles which were detected in the lungs after a dose of breath actuated MDI, which is significantly higher in the actuated deliveries. Autohaler was the first registered, which was the first commercial device which was marketed in this group. With now it has got some new modifications, which is being marketed with the name of Synchro Breathe, in which they have removed the top lever, which you can see in this diagram. This lever has to be pulled up to activate the inhaler, and in this you have to just open the knob, the cap of the inhaler, and the inhaler gets activated, and flap in open position gets it's activated, and once the patient inhales deeply, the dose is delivered. So these are the new innovations in the MDIs, which has led which has overcome some of the problems with meter dose inhalers. DPIs are easy to administer, no coordination is required, they are flow dependent, and device and caps are to be carried separately. They can be single dose or multi-dose. Here you can see variety of single dose inhalers which are available in the market, and multi-dose inhalers which can be discrete or reservoir. Discrete means use and throw. One device is available for one-time use, that is some 60 doses or 120 doses will be there in one device. After that you will have to buy a new device. However, the reservoir device have got a cartridge that you don't have to replace the device. You can use the same device for long and keep on replacing the cartridge, which is in Nebulizer and turbohaler. Others, one single-use devices are multihaler, ellipta, actuated, etc. Nebulizers are devices which everybody knows that they are used to transform liquid formulation and suspension into aerosol. There are of three types: jet, ultrasonic, and vibrating mesh. Jet nebulizers are cheap, easy to use, but they have insufficient drug delivery. They are noisy. They have poor dosing control and require changes in the ventilator settings also when used in a ventilated patient. Improvement have been made with new baffles and to improve the particle size, and they have incorporating breath to increase fine particulate fraction and improve the drug delivery and reduce the drug loss. These are various type of nebulizers, that is the ultrasonic, jet, and mesh nebulizers. Some studies were done on the drug deposition with various devices in last 20-25 years, and it was found that the drug deposition with a dry powder inhaler with a 60-liter flow was only 6%, and to achieve 13% deposition, 13% of the drug which is emitted, of the emitted fraction, you have to have a flow of 120 liters per minute, which is practically not possible in patients who have got moderate to severe COPD, and impossible in a patient who has an acute attack. So in these situations, DPI cannot be used. DPI is not a single-use DPI is not a preferred device. In MDI, you can see that there is lot of oropharyngeal loss, that 80% of drug is lost in the mouth. There is lung deposition of 8.8% only. However, with the help of spacer, the drug delivery can be definitely enhanced, and it has been shown that the drug delivery with using MDI with a spacer can range from 12 to 15%, which was the largest fraction of drug deposition deposited amongst the most of the devices till the recent past. Similarly, you can see the amount of drug which is deposited with the nebulizer is 12.4% only, and about 66% is lost in the device itself. So the drug deposition is comparable between a small volume nebulizer and the MDI, that is meter dose inhaler with spacer. The question which comes to everybody's mind, that are all inhaler devices similar in efficacy? The answer is no, they're not in similar in, as I was just describing the comparison between various aerosol delivery devices. You can see that largest deposition was in another study was shown to be with the pressurized MDI with volume holding chamber, which was significantly higher with small volume nebulizer also. So in short, you can say that best drug delivery amongst all devices is obtained by using a pressurized MDI with a spacer, which can be an electrostatic spacer or a non-electrostatic spacer, which are available in the market. Similarly, a meta-analysis was also published in 2005, in which it was evaluated that there are differences between various inhaler devices. The answer was no. One should use the cheapest pressurized MDI. That is, the answer was pressurized MDI was slightly superior to dry powder inhaler devices, and one should go with the cheapest pressurized MDI available. Why these problems occur with the patients when patients do not respond to aerosol therapy? It is because there is no formal training given to the patients most of the times, because of a busy schedule or various reasons. It is taught by people such as chemists and people who do not have exact knowledge about these devices, and till the patient is asked to demonstrate, show me how do you take the inhalers, neither the patient nor the doctor is aware of the problem. And many of the times, the physician, the nurses, or the trainers themselves do not exactly or know how to use the pressurized MDI or the device correctly. So the question is, which device to be used? The factors which are to be considered while choosing an inhaler device, it is not a one person's job, or it's not an answer which can be given in black and white. It depends on various factors, that is the type of obstructive or the obstructive airway disease, its severity, that is the magnitude of airway obstruction and the expected flow rates, age and gender of the patient, occupation of the patient, socioeconomic status of the patient, and comorbidities such as neurological comorbidities which can affect the coordination or hand-to-mouth coordination and the performance status of the patient. Patient acceptability would be best if the device is easy to use, It has got feedback mechanism which can be visual, acoustic, or taste. It should be robust to use, should have a method by which a person should be able to know how much dose is left in his device, and it should be available with wide range of drugs delivered through the same inhaler. So in that situation, one has to use individualize the choice of the aerosol delivery device. And MDIs as the first choice is usually in young and adolescent adults who are well educated, who have better socioeconomic status, and do not have any neurological illness which interferes with hand-mouth coordination. Single dose DPIs are the commonest and the most used devices in all areas at the primary health levels, secondary health levels, but there are problems that each dose has to be loaded before use. It can be inconvenient at the time of acute symptoms, and the device, if left open, can be exposed to moisture, and the drug delivery can be further jeopardized if not stored properly. These problems of dry powder inhalers have been overcome by multi-dose DPIs, and they have got multiple advantages as compared to PMDIs, the pressurized MDIs, that they do not have any environmentally harmful propellants. They are activated by breath, so they preclude the need for any hand-lung coordination. They are small and handy to carry, and multi-dose preparations have made DPIs very attractive. They could be the future inhalation devices, and a lot of innovations are being done in this field. One of them is the Turbohaler, which is marketed in India by the name of Turbuhaler, and it is available in a combination of long-acting beta agonist and budesonide. It is handy. It has got a reasonably good deposition, and up to 25 to 30% deposition is claimed, and it has got good acceptance to the patient because it's small, it is handy to use, and easy to carry also. Similarly, Nebulizer is a multi-dose reservoir device in which you do not need to change the device, and it has got a very good patient feedback system in which there is a window in which the device turns red as soon as it is fired, and in the loaded stage it shows green. It is loaded through this knob, and this is the place where the cartridge, you can see that the cartridge can be replaced, and it has been shown that at a flow of about 90 liters, 30% of drug can be deposited, and it has got good patient compliance, and a lot of patients are very happy with these kind of devices, which are reservoir devices, and they have to just replace the cartridge and do not have to replace the whole device again and again. Recently, a soft mist pressurized MDI, that is SP MAT, was also introduced or released. It is a propellant-free soft mist inhaler in which a mechanical energy in form of a tensionoid spring is used as a propeller, and it generates a aerosol plume. When the dose release button is pressed, the energy from spring forces the solution to the mouthpiece, creating a soft aerosol plume which lasts or remains suspended in air for 1.5 seconds, making it easy for the patient to inhale, and it has also got and also been demonstrated to have a very good lung deposition. So there are a lot of innovations being done for development of aerosol delivery devices, and to maximize the drug delivery and give the most therapeutic benefit to the patients with obstructive airway diseases. Prescription of DPIs or DPI devices should be done on the basis of usability of the patient, and particle size distribution of the emitted drug, airflow resistance of the device, it should match with the inspiratory airflows achieved by the patient, and affordability. One should while prescribing DPIs, one should formally see how much negative flow a patient can generate, whether or not he will be able to inhale the particles or able to activate the device or not. It has got very important impact on the symptomatic benefit achieved by using these devices. So, and during mild exacerbation, DPI devices may not deliver adequately due to very poor inspiratory flow rates, and MDI reliever medication or a nebulization should be kept as a backup measure. So finally, the question is that who decide which inhaler is to use? It is the doctor or the patient. Obviously, the answer is the patient. If the patient does not like the device or is unable to use it correctly, it is useless. And a preferred device that is taken by the patient and is effective represent a better value for money. Summarizing, the aerosol therapy has been the cornerstone and is the first line of therapy for management of obstructive airway diseases for more than 15 years. And it has witnessed many advancement in the recent times. Improved aerosol generators with different drug formulations are available. There are advantages and disadvantages associated with various devices. MDI with or without valve, with or without a spacer have emerged as a preferable device, but requires good coordination and may be inconvenient in some patients. Breath actuated devices may require higher inspiratory flow rates and may be difficult for patients with limited capacities. The choice of device depends on medication prescribed and the abilities of the patient. Patient needs to be well informed and feel comfortable with the use of chosen device, and effective delivery of aerosol medication is primarily dependent on correct technique, and it is essential for health professionals to keep up to date and proficient with all delivery systems. Thank you for your patient listening.